it's been a ton of fun to be a part of it. And, so this, I wouldn't have expected to change something in my practice. I'm 4.5 years out from fellowship, this early, dramatically change something. All I do is shoulder and elbow, and so rotator cuffs, probably do 5 or 6 a week. And so to change what I do more than anything else this early in my career was something, if you had told me leaving fellowship, I would have said no way. And it's been a ton of fun. I enjoy doing the cases more. I think there's more fun than anchors, to be honest with you. You can get more.
I agree. I think anchors are so old and easy, and they make such big holes when you're used to seeing the smaller holes,
Yeah.
And the suture configurations are so much more creative, and there's so many more options that you can do. It was a lot more fun for me. I agree. I was getting kind of bored. What was your learning curve, when you started? 3, 4, 5 cases, more?
Yeah, I mean, I said I'd already been tying, and so that came naturally. It was just kind of practicing in my mind how I was going to, sitting with you with the model was helpful and seeing how the X-box, the peripheral, sutures, the sliding knots, stuff like that. Just doing that outside the body a couple of times and knowing where I was going to put my knots just helped me to feel more comfortable going in there. To get the flow with my my reps and like what them to expect, it takes a couple cases, but really a couple cases. I mean, it was not a big learning curve in that regards.
We got something brought up here from Brad, and maybe Bill can address this as pretty high volume arthrotunneler users from the past. We had a lot of docs that were going to adopt, and they said, "Oh, I tried that, and it was so futzy in the past. It was hard to get the thing to work and hard to pass." And I've even had a couple docs say that, they watch the video of the Transos and they say, "Well, there's no way it's actually working that easy." And then they try it and they say, "Oh, well, it actually does work that easy." But, is it, what Brad, you've done tons of arthrotunneler. What do you think is the most salient improvement from the first mover to an improver like the Transos?
Well, we were talking about pullout earlier, and one of the biggest issues with pullout is how many passes you make to pass the suture through a given tunnel. And with arthrotunneler, there were occasions where you couldn't quite hit the hook or hit the wire loop, and you'd have to make another pass, or maybe 2 more passes with the drill bit to make sure that you were passing to the wire loop. And so you might have had 2, maybe 3 tunnels to finally pass your suture through, where with tensor, it's one and done. It's one pass, and it's a much more lower profile coming in from the lateral side. It's penetrating the bone without having to be pre-drilled. So it's much more accurate. It's a much more sturdy device. It feels much more substantial in your hands. You do the single pass, and it's far less traumatic to the bone. So if we're differentiating arthrotunneler versus tensor, the biggest thing is less trauma to the bone. And it's just that simple. You're going to have far more consistency with that pass, and I think it's going to lead to less frustration with those who are converting from anchors over to transosseous. It's pretty satisfying the first time the surgeon hits that hook and pulls the suture out. They've passed the suture. Once they've done that, they feel like they've got it. And they're going to get that with tensor far more than arthrotunneler on a given pass.
Bill, any thoughts on usability?
Yeah, I agree that the arthro tunneler is a bit futzier. So like Brad was saying, occasionally you have to drill multiple times and kind of change the angle a little bit. And again, that probably kind of weakens the lateral tunnel to some degree. The Transos, you put the awl in there and it grabs the stitch. It does it. I mean, it works. It doesn't miss. and again, that probably, like you're saying, compacting the bone rather than drilling the bone probably increases that strength of the strength of the lateral tunnel and prevents cutout. The other thing is the transos is a bit bigger. So if you have a bigger patient with a wider tuberosity and you really want to recreate that entire footprint, you have better ability to do that with transos. The tunneler's a little more narrow, so you can't make as big of a footprint recreation as you can with the transos. So, you know, occasionally you'll run into that with a bigger patient. Transos, you can get lower down on the lateral proximal humerus as well. But especially for someone who's switching from anchors to transosseous, transos is easier, it's less futzy, it's going to miss less. So there's way less of a frustration level that's going to be there.
Great. Yeah, that hook on the outer shaft of the transos was designed, you know, from an amalgamation, a CT database of the, you know, average volumetric CT scan of the tuberosity. So it generally will recapitulate the surface area, you know, of most of the tuberosities, as you allude to.